Now our next speaker will be Dr. Madhusree Sengupta. She is consultant physiatrist in RN Tagore, and she will be talking on acute stroke care and rehab.
A very good afternoon to all. Dr. Kaushik and Dr. Arvind has already set the prelude for early management of stroke, because the first criteria for a successful early rehabilitation of stroke is timely referral. So which is what they promote, which is what every stroke physician should be promoting. So what is early rehabilitation? Now, early by definition, you will come across in literature different things. Some say in the emergency itself. Some literature says it is between 48 to 72 hours, and some say it is as soon as the patient is hemodynamically stable. Well, all are acceptable, but if I put together all the knowledge, less than 24 hours, rehabilitation is probably not going to be too helpful. Better to keep it somewhere between 24 to 72 hours, and definitely as soon as the patient is hemodynamically stable. So in our hospital, we have a KPI, that's key performance indicator for the rehab team, that every cold stroke patient within 72 hours has to be attended by the physiatrist. So why do we emphasize on early neuro rehab anyway? Because as we know, brain is going to recover to a certain extent on its own. There's going to be some neurogenesis as well. Then why? Why do we have to start early? Because we want to get the benefit of both. So the unique neuroplasticity that rehab is going to target, that lasts about 1 to 3 months in humans. And the unique plasticity mediates, there is a spontaneous biological recovery, as well as when you are applying your rehabilitative measures, you want the neuroplasticity to develop as well. So brain has to regenerate, brain has to adapt itself, make the best of both. So start with early rehabilitation. So why, what are the objectives? Now, in stroke, if we think very logically, when you're adding medicines, when you're doing the acute care management, it is to save the life, number one. Number two, to prevent recurrence of further stroke, that is when the lifestyle and all the medicine comes into play. But to recover from the damage of the current stroke, you need a very good rehabilitation program. So you need to prevent further loss, reverse damage if you can, restore function. If there is any functional impairment that you can, with compensatory techniques, adapt the patient, do that, and teach new things to the patient. So stroke is a journey, and earlier, the faster you incorporate that thought in the patient and the family's head, the better it is. That life may not be exactly the same, but life might change and you have to adapt to it. But make sure you reach your best functional capability. That's what stroke rehab is about. Now, patient's pathway after acute care, where will a stroke patient go? So, if a patient is doing perfectly well, patient goes back home. If I use the NIHSS, that is stroke screening score, 5 or less, patient can go home or outpatient neuro rehab. If it is between 6 to 13, that is the fantastic thing, because as a neuro rehab physician, that's where you will be able to make a lot of difference. Go for inpatient neuro rehabilitation. If it is more than 13, even then, inpatient rehabilitation is going to help, but be prepared, it might be a prolonged rehab, or you might have home care facilities, need home care facilities as well. Now, there are lots of predictors, because patients will, once the life is saved, family is going to come to us and say, what do you think? Does my patient have any hope? There are a lot of prognosticating factors, but the basic ones, what was the GCS score at admission? What kind of stroke was it? How large? Which area? What is the age of the patient? Is there associated things like a myocardial infarction, or whether there is any visuospatial defect or something that makes the rehabilitation even more challenging. So if I look at a neuro rehab team, this is what a neuro rehab team component should be. There should be a neuro rehab medicine consultant. Now that can be from a person with a physical medicine rehabilitation background, preferably. We also have neurologists who train themselves in neuro rehab medicine. ITU rehabilitation nurses, paramount importance. Physiotherapist, speech and swallowing therapist, occupational therapist, preferably a psychologist. I'll come to that. Now, what is occupational therapist? Occupational therapist, many setups are not comfortable with the term or not aware of the term. It means that you should go back to do the job that you're meant to do. So what about a homemaker? It means she goes back to doing the job that she was doing. What about a child? He goes back to do the job of playing and schooling. So that is what an occupational therapist does. Help you functionally achieve as much as you can. I emphasized on occupational therapy because it's my favorite part of rehab. So if I look at the components of early rehab, of course, the optimization of medical management, care of tubes, which is Ryle's tube, tracheostomy tube, catheter, everything that you have. Start the course of physiotherapy and occupational therapy, speech therapy, Ryle's tube. I'll take them up one by one. Cognitive rehab. Now this is again a bit confusing. Like in the ITU sector, why would you start off cognitive rehabilitation in the first place? I'm not going to get into the details of delirium because it's been taken up fantastically by Dr. Kostu. However, when I say cognition, it means making the person oriented with the senses. You know, exposing the person to multiple senses so that they get their self back. Positioning, chest PT, mobilization, use early orthosis. Again, this is a very ignored, neglected portion. And most of the time when as physiatrists, we get a patient, a subluxation might have happened, a contracture might have happened, and all these were preventable in the first place. Early detection to neglect and apraxia. Like I said, these are difficult to treat areas, but easier to treat if you catch them early. And use of technology, of course, wherever you have. First, you have to prevent pressure sores. Nurses are of paramount importance here. So positioning, mobilization, skin care, offloading. So it has to be in sync with the nurses as well as the physio team in your hospital. Use proper cushion, a wheelchair which has a reclining facility, and the right caregiver. So like somebody mentioned, there is the concept of family that has also come into play now. So whoever the caregiver is. So these are certain ways by which you can prevent the pressure sores. You can use a mechanical hoist, so the friction while transferring the patient is avoided. Sometimes we do a lot of harm ourselves, and we have to be aware of these small things like wrinkles on the bed cover. Don't pull the patient. Use a transfer board if you can. Use a mechanical hoist if you can. If there's a if there's a wheelchair with a tilting facility, use it if you can. Make the person stand up if you can. So prevention of pressure sores. Prevention of contracture and subluxation. Now, like I said, orthotic management is very important. Now, if you look into my right side where I've made a cross, that is a posterior leaf spring AFO. Now, it's not exactly a big no, but I'll explain the concept. It's commonly known as the foot drop splint. See, when the person doesn't have spasticity, you need to keep the foot more or less in the neutral position. This is okay. This will suffice. But if the person has developed spasticity, this is nothing but an ornament. In that case, better to go for a fabricated one, a proper AFO, which is measurement is taken, and an orthotist will make it for the patient. You can use a Bobath cuff or a humeral cuff for early subluxation. Again, this is one of the key points of clinical audit, which we have recently introduced in the rehab team, that every patient within 72 hours, the caregivers, they have to be aware of what subluxation is, and at discharge, we will explain how to prevent subluxation further and take measures if there's already any subluxation. We aim to make it zero. That's the wrist hand orthosis, again, to prevent the contracture of the wrist, the flexor tendons, because contractures are tough to handle, and contractures take away a lot of your functional ability. Sometimes what you're thinking as contracture might be spasticity, an MAS3 going towards MAS4 spasticity. So if we can prevent contractures in the early stage, you're actually making the job easier for both. So positioning, chest PT and mobilization. This is again a key requirement in the early ICU, and it requires a collaborative team. So there has to be a mobility team in action. That is the nurses, the physios, the PMR doctor who's taking care, the critical care doctor who's taking care. You cannot just, pull a patient who is drowsy, who is not hemodynamically stable, and make the patient sit and say that, okay, fine, I've mobilized the patient. That's not how it works. Patient has to be ready for mobilization in the right way. Even sitting on chair, dangling, supported sitting, giving a belt if necessary. These are also parts of mobilization, not just walking. So somebody had mentioned the RASS scale, I think Dr. Kaustub. That is a very good way. So if the patient is agitated, if the patient is under side effects of other medication, you take a very cautious decision how to mobilize and how much to mobilize, but do mobilize. So start off with a good chest physiotherapy in the beginning itself. Again, this is a domain of both the critical care as well as the neurologist, rehab medicine, physiotherapist. Use an inspiratory spirometer, help in the postural drainage and upright positioning, gradual vertical orientation. Now, when I'm talking about mobilization, often because of knowledge gap, I would say, sometimes when we get referrals, doctors tell us of other fields, all I want is my patient to walk. But you have to understand, walking is the goal. It is not the starting point. There has to be steps through which one goes, and that is where the PMR doctor, the neurorehab medicine specialist has a very important say. That is where you're going to plan how the mobility should progress. So if you look at this, first is the tilt table, where you're handling the orthostatic hypotension. Second, you can use a body weight supported treadmill training. Person is unable to walk, but the person gets that all the benefits of being upright. Then you move on to a supported, standing frame. Then there can be a walker or a walking cane. And then look to the right side, the patient is on a bicycle. So you go step by step. Now, a lot of referrals we get for prolonged disorder of consciousness. That is where the coma stimulation is of use. And if it's also, the word has changed now, it's disorder of consciousness. And if it is beyond 28 days, it's a very poor prognosis, it becomes a persistent disorder of consciousness. So different stimulation are used, like sensory, pharmacological, music therapy, median nerve plus minus, hyperbaric oxygen, transcranial magnetic stimulation. This is largely best done with a physiatrist and an occupational therapist. So I always joke with my occupational therapist that just start the spa therapy. So what's the spa therapy? She comes with the tray, with the different smells. You need to know the person's background. Speak to the family. What kind of music did the person like? What kind of food did the person like? If the person was averse to biryani, you can't just make the person smell a biryani and think this is doing good to the patient. And transcranial magnetic stimulation, I won't go into too much detail. There are colleagues here who have done far more work than me in this domain. Pharmacological, again, there is a lot of plus minus. To the best of my knowledge, amantadine has a body of literature in support. Modafinil can be used. Memantine has some role, and levodopa. These are the drugs which are commonly used and recommended. There has been mention of coma stimulation even in our early Vedic literature. So probably our ancestors were more scientific than we give them credit for. So what is coma stimulation? The different stimuli are used: auditory, olfactory, visual, and it's very individualized. And you might have to do it multiple times a day because too much of stimulation can be agitating.
2 minutes to go.
I'll try so. I will not get into the details of music therapy, but yes, it does have role in arousal and cognition. There is science behind it, and it is also an auditory stimulus. Now, occupational therapy is, in 1927 itself, it was called a form of psychotherapy. Why? Because here, you have two parts. You have a cognitive behavior therapy, which is talk-based. You are also involving the patient into activities like play, art, and writing. So, a person becomes like a child after stroke. You have to start with basics. Identify the color, identify the object, where is the crow, which is the guava. Then get them into peer bonding. So, to my right, this picture that you have are of 2 stroke patients about 2 weeks old. And so now they have started playing Ludo. And I don't have the video, but they were fighting over the colors. You have to recognize visuospatial inattention. So this is a person with neglect, and you can use prisms or modify the glasses like we have done. There are other cognitive based therapies. Important is mirror therapy. Now see, sometimes even if you can't do something, when you observe something, you learn to do it. How? Because your mirror neurons get activated. Same principle works in stroke. even if a person can imitate something in the early stroke, that's a good sign. You can work on it. The psychiatrist before me, Dr. Debanjan, has taken up all these in so much detail, but there are a lot of psychiatric or cognitive behavioral abnormalities that you come across. I will take another minute or so. So there can be post-stroke depression, psychosis, anxiety, stress disorder, mania, emotional lability, fatigue or apathy. And as a physiatrist, you can play around with the medication because there's no one-size-fits-all theory. There can be tricyclic antidepressants, SSRIs, modafinil, cholinesterase, donepezil, etc. that you can use. Again, dysphagia, you need to throttle it. Otherwise, it's going to lead to a lot of consequences. So how do you screen in the bedside? How early? As soon as the patient is alert. If the patient is alert, within 4 hours of admission, you can screen for dysphagia. Try with one consistency. We usually do not use water, but either thickened liquid or something like a curd consistency. Start with half a teaspoon, gradually move on to 4 to 5 teaspoons. You can use this scale, which I personally prefer, gagging, swallowing and screening. That is, how is the cough? Is there a wet cough? Can the person swallow properly? And is there any intonation? So a speech therapist, swallowing therapist, along with this is also going to teach a lot of swallowing maneuvers. You know, first with dry swallowing maneuvers, like chin tuck, how to hold your jaw, how to hold your lips, and then gradually move on to those with food. So this is an example of FEES, which is a bedside investigation that you can do. Ideally, modified barium swallow can be done, but it's time consuming. There's the different dysphagia therapies like exercises and compensatory techniques. Now, if it is for short term, you can go for nasogastric tube for feeding. If it's long term, think of a PEG tube. By long term, I mean more than 4 weeks of nasogastric tube. Spasticity. Again, this is the most disabling part of post-stroke sequelae, and spasticity can be managed with a combination of splinting, oral drugs, botulinum toxin. Previous talks have already discussed this in detail. If necessary, surgical intervention. I'm a part of the ASTER program where we have a protocol for spasticity. We'll be very happy to take a session in your institute. If you invite us, lunch will be on us. It's about a 1-hour session. So there are other different aspects of rehabilitation which we use to bring the best out in a patient, like CIMT, constraint induced movement therapy, telerehabilitation. Of course, nothing in today's world is without telerehabilitation. A stroke might happen in the village, you might be in a metro city, but you'll still be able to handle it. Robotics. Robotics earlier was propagated more for subacute and chronic stroke, but now even in acute stroke you can use it. Gives a lot of purpose to the patient that even with zero power in my limbs, I'm doing something, I'm moving. Virtual reality, we are very used to this term in all malls, but it's got a huge scientific literature backing, helping in neurological recovery. So there are others, like I already discussed the body weight supported treadmill training. You can use functional electrical stimulation early to prevent atrophy as well as to promote function, and EMG biofeedback, where the patient can see the graph of the muscle which the person is using. The different types of neurostimulation. And so in the future, somebody has already mentioned early in bed cycle ergometry. It's not so futuristic anymore. It's there. We can start off.
Come to your conclusions, please.
And there's also the brain-computer interface, AI. Artificial intelligence is now coming up with a lot of newer ideas on how to work with early stroke. But in rehab, we have always had AI. And so the take-home message, no rehab potential is a myth. Every patient deserves a chance. Early neurorehabilitation is the key. Use your clinical knowledge, individualize skill and technology. A big thank you from the Department of PMR and Neurorehab in Narayana R.N. Tagore Hospital, Kolkata. I'll be happy to take questions.
Only one question is allowed.
Yes, sir.
Or splint?
Facial orthosis splint, sir? See, sir, I haven't found too much literature on this, But earlier when we were at Institute of Neurosciences, there was this something like this we pulled just to keep the droop of the angle. It is given to, I'll come to that, sir. So it is given to prevent the drooping. But however, if the facial weakness is because of the stroke per se, facial exercises should be sufficient. After a certain point of time, let's say about 3-4 weeks, you can start facial electrical stimulation. Orthosis is not going to help you too much, but it can be a supportive or additive thing in the facial palsy of a stroke.
I think it cannot be given. It should be given in the Bell's palsy only.
That's what, sir. I haven't found literature, but yeah, we have used it.
Okay, thank you. Thank you, Madhusree. Now we end this session.